So welcome everybody to today's session for the Adelaide Biomed City discussion series. It's good to have you join us. My name's Susan Hillier. I'm the Dean for Research at UniSA, and I'm really delighted to present some of our finest researchers today from our academic unit called Clinical and Health Sciences, in particular from nursing and midwifery. And I'm sure you'll enjoy hearing about their groundbreaking research. So firstly, can we just pause to acknowledge that those of us presenting, we're meeting on the land of the Kaurna people, and we pay our respects to elders past, present and emerging, and we acknowledge their ongoing relationship and linkage to the lands. So our first speaker is Professor Marion Eckert. She's the Director for the Rosemary Bryant Research Centre at the University of South Australia. The Rosemary Bryant Centre is a very prestigious centre set up to look at various aspects of research around nursing and midwifery practice. Marion herself is a nurse with an extensive CV around being a nurse clinically, being a nurse manager, working obviously in policy and research, particularly in the areas of cancer. So, Marion, over to you.
Thanks very much, Susan. So I'm really pleased today to give you a little bit of a snapshot of some of the research that we're looking at and pursuing, particularly related to predictive risk modelling to inform clinical risk environments. So just a little bit, Rosemary Bryant, our research centre, has a vision and a mission that we're working through and a strategic plan, and on the slides there is the link further down later on. So the areas I'm just going to touch on today is really looking at predictive risk modelling. Why do we need to do this in our health system? What we want to achieve with predictive risk modelling, the process and our data sources that we can potentially use, and significant predictors that are currently reported in the health system. So I guess to sort of try and cage predictive risk modelling and think about what does it mean, most people are familiar with McDonald's, and when you go into McDonald's, they already have predictive risk algorithms where they know whether it's breakfast or lunch, and even if it's straddling that time in between, what potentially you would be interested in ordering. They know now what they need to order in 2022, how many burgers, how many buns, what their staff ratio would be 12 months ahead. So really this process of being able to use predictive analytics is something that we're really interested in, and how it could be applied within the health system. Even though we're not quite McDonald's, the formula and potential process around machine learning and AI is potentially very similar. So what is predictive modelling in healthcare? So it's really looking at the clinical information that's already potentially there to predict future healthcare needs, using the data that's there, the analytics that's there, and then combining that to give information that then looks at predictive risks rather than looking back. So it's about being able to see the storm before it comes and before it happens. So why do we need predictive modelling? Well, often in health we do have a understanding that we do know that there are risks, and we do know that there are events and incidents occur every day in the health system. And often when we're doing the reporting and looking, a lot of the time it's based on data that's fed into the system, and we're often looking at the events after they've occurred. So we look at falls, we look at medication errors, we look at code blacks, but it's always after the event. And what we're wanting to see is the ability to be able to use some of this past data to be able to then look at how you predict risk for the future. What we're thinking about wanting to achieve is really about how do we analyse the data, look at the data that comes into the system. So this is data that's related to the safety learning system, empowering clinicians to think about risk and act on some of those predictors, and then also to identify predictive factors in data correlations, really with the aim to reduce harm. What we'd like to consider is the process around understanding and defining the data to make sure that the data is clean when it goes into the system to be able to give you accuracy around predictive risk modelling. And then what is the outcomes, or what are you trying to see around building the algorithm in terms of what you're wanting to look at to be able to then predict. And also, because the health system is so rapid and it is a high functioning environment, it has to be visual so that people can be able to see that in brief summary and then to be able to act on that. So looking at how you provide actionable insights. So a process that we're interested in is looking at two areas of flow. One is related to mental health areas. So looking at trying to understand when people navigate their way into the health system, what are some of those risks that occur, what are some of those adverse events, and then potentially using the algorithm, putting that information in through to the system to be able to predict risk. And then being able to develop and validate a specific predictive model for risk outcomes. So some of the sources that you may be familiar with or have seen is looking at the diagnostic related groups, understanding the demographics of the patient. So if you understand these demographics and the diagnostic related groups, it creates a risk already, whether that patient has been readmitted within 28 days, looking at the occupied bed days, so how long that patient has been in the hospital, and then looking at their polypharmacy profile, and then combining that with what we're really interested in is looking at it in combination with workforce data. So not just the profile of the patient and the demographics of that ward environment, but also with profiling it against the actual workforce data. So whether that's permanent staff, agency staff, casual staff, or whether those staff are not familiar with the environment. So one of the two areas that we're really interested in is in medication incidents and falls incidents, because we know that medication incidents are very common in the hospital. They happen every day, and also they can be very costly to the hospital as well as the individual. Falls are the same. They're very costly to the hospital. They increase length of stay. They can decondition people quite significantly, and also can have quite a toll on the individual. So just an example of what we have done in the past when we did combine this information from 3 years of data that we have used. We did identify that there were high risk ward areas when we did use the analytics, looking at SPSS modeler, trying to understand when we overlaid the workforce data, we did identify that there are greater risks in those ward environments. Some of those greater risks that we did identify was around the casualisation of the workforce, the agency and sick leave. So when you have staff absent and you have staff replace those staff, or you have very casual workforce who are not familiar with the environment, that increases the risk of incidents. And if you are a clinician listening right now, you might think, well, yes, that's very obvious. But one of the challenges that we don't have at the moment is being able to quantify those risks in any sort of formula, so that when people are ringing up and saying we've got risks here or potential risks, we're now wanting to look at a platform that gives clinicians and managers or people who are making arrangements around the safety of the staff and the patients some sort of quantifiable base to work from. So some of those significant predictors, when you do combine them, you do have significant events and you do have errors. So what we would like to propose is that we identify what those predictors are and those risks are, to identify those hotspots within a particular risk population. So for example, if you're looking at a ward within an environment, a medical ward, and you can identify that there are predictive risks in that environment for the coming week, then there would be changes made to that workforce environment and that environment to make sure that that was a safer environment. So looking at some sort of dashboard as a model for the future so that people can look at it and go, okay, we've got a risk, medium, low or high, and be able to then adapt and change care accordingly. So we have been involved in this for a few years, and we were fortunate enough to present this information to an NHMRC research translation forum, really focused on that we need to stop looking back because the events already happened, with a view to look forward. And we're really fortunate at the moment. We're just liaising with the Digital Health CRC to potentially get some support to progress this research. So in summary, we really want to be able to translate the data to forecast the future so that we can improve patient outcomes and really remove some of that waste in the health system.
Great, thanks very much, Marion. Austin Milton, a very interesting presentation, thank you. Does your earlier graph mean that around 18% of medication errors coincide with a casual workforce?
There was a correlation to the casualisation of the workforce, and it was identified as a significant risk, yes.
Great, okay, thanks, Austin. All right, so, and thanks, Marion. We'll now switch to Dr. Mark Loughhead, who's also a colleague at UniSA. Mark is part of the research concentration looking into mental health and suicide prevention and education around those topics. His background is in mental health policy, and the position that he holds at UniSA is as a lived experience academic. So, Mark, if you'd like to share your screen, we can talk a little bit. So Mark is presenting on behalf of the Suicide Prevention Group, which and the director of that is Professor Nicholas Proctor, who some of you may know as well. Okay, thanks, Mark.
Thanks, everyone. It's good to be with you today to talk through the group. So acknowledge the Ghana elders past, present and future, and also like to acknowledge people listening with lived experience of mental health challenges as well. I'm presenting just really an overview of the group today in some of the areas of research rather than a specific project. So one of the really interesting things about, I guess, the focus of the Mental Health Suicide Prevention Research and Education Group, it's a bit of a mouthful, we see really three key areas that are really important for us, and that is research which is applied and connected. And that's with our industry partners through engagement. And, you know, with mental health, there's a whole range of stakeholders involved. And in the education area as well, which includes professional development out in the sector, and also the UniSA offerings, particularly in our graduate diplomas of mental health and mental health nursing. We produce, obviously, research publications, but also industry reports, films and podcasts that really encourage change in the sector and the development of fresh practices and innovation. And our focus is often around what's called trauma-informed care. So working within mental health, not so much from a medical illness paradigm. It also includes science on the impacts of trauma and how that transfers into ways of working that recognise trauma amongst populations, people with lived experience who are using mental health services. We've also got to focus on refugee and asylum mental health and rural and remote as well. We have a variety of funding processes with state and Commonwealth leaders and a mixed portfolio or mixed income from those different streams, where Nicholas is often leading consultancies that come in from different agencies. One of our chief funders is the Office of the Chief Psychiatrist in South Australia, which lends us to doing a lot of work with the local mental health nursing and allied health workforces. So some of that is around supporting communities of practice around different topic areas, and also holding key events and working from a philosophy of shared learning. So it's not so much just research towards education, it's actually, and the field, it's actually learning from the field and working together in that way. For some of you who work in mental health or have understood the challenges facing mental health services, they're very significant. There's recent Productivity Commission report into mental health across Australia, identifying a whole range of systemic issues that need to be addressed, in the design and delivery of services to meet different needs. There's fragmentation, there's under-resourcing, chronic under-resourcing, and there needs to be sort of innovation in the way our programs and services work alongside individuals and families. And a real focus on compassion, and not actually doing to, it's working with and working alongside people, because mental health, really, when you have lived experience of mental health issues, it's a quite complex experience, and it involves a whole lot of learning, as well as, you know, the psychological, medical interventions that you might be a part of or might experience. So I just really wanted to focus on some of the HDR industry scholarships we've got active at the moment. So these have been generated through our partnerships, and you can see there some of those with Borderline Personality Disorder Collaborative in South Australia, with Mind Australia and NEMI National, who are national NGOs in the mental health space, with a local organisation called Uniting SA, and with another national group called Mates in Construction. So we've got a range of interesting projects that are led by, I've got the candidates listed there who are working on those. They're all panel supervised and have interesting methodologies, particularly around action research and co-design, and but also elements of quantitative research as well, so that students who are working on this work have that mixed experience of qualitative and quantitative approaches, but they also have research methodologies which invite people to be a part of that. And we have some lived experience leaders and industry, other industry or professional leaders helping in the design of those research processes. So that's really interesting, and that's, I guess, Nicholas has helped to generate those partnerships and those connections, and it's a really, I think, a valuable way of working and connecting to ensure the relevance and reach and translation of the work we do. The last one we've currently got open, which is an evaluation of the model of care being developed within Adelaide's Urgent Mental Health Care Centre, which only opened in March, and is it's a crisis response-based alternative to ED for people experiencing mental health crisis. The other focus I wanted to look at today is a project that I'm leading called Activating Lived Experience Leadership. It's an action research project that's in partnership with the Lived Experience Leadership and Advocacy Network of SA, and we're funded by Faye Fuller. So Ellie Hodges, who heads up Lelyn, that's that organisation, is a project lead, and we've done a range of innovative research with lived experience leaders and mental health clinical leaders and policy leaders to look at how do we actually raise lived experience leadership in South Australia so it's better valued and recognised. And so what that means is, so the voice of people who have been through our services and have a significant mental health journey are in positions where they can share around service planning, evaluation, be a part of commissioning decisions, be a part of planning, so that we have a more, I guess, our services are planned from different perspectives, and they meet the needs of people in improved ways, and there's innovation in that space. So part of that is looking at commissioning as well. There's an ever-increasing non-government mental health sector in Australia, and there's also the NDIS as well. So the commissioning of programs in the psychosocial disability space and in primary health is a really interesting thing to target in lifting the profile of lived experience leadership. So that's been a really interesting process, and we're sort of reporting via a mix of industry, which is what, when we've done the research and we've had significant influence, and we need to write that up so that people can act on that now, in a sense. So that always offers a challenge with that context of producing journal articles, which, you know, maybe take many months to actually produce and get through. So it's an interesting process to balance that industry and journal publication process. So probably been quite quick there, but it's really just to give you a snapshot and a quick overview. You know, to contact us, please get in touch with Nicholas or myself and let us know what your interests are and ways of working together. So thanks very much.
Great, thanks, Mark. You know, I guess because you're working really at the coalface, aren't you, and trying for some system reform, I'm gathering that you need to get a lot of executive buy-in for your work. So how do you go about that? You know, when, you know, these are big issues and, you know, if you want service reform, implementing change doesn't happen without.
Yeah, I think one of the things we did, and Nicholas and Ellie working together, we held roundtables during this project, and we did that very quickly once we were funded. We had an initial roundtable, you know, with significant attendance. We had about 25 leaders who came to that to identify what are the systemic issues and barriers for really for people to be involved at higher levels. And then we took those suggestions that we've got. One was for a community of practice to be established around leadership. One was for we need a statewide framework to help guide service development. And the other one was we need a backbone organisation to drive this sort of systems level work. And so we did that, and we had a reasonable engagement. And of course, then COVID hit, and so we've had some disruptions, but we managed to have a follow-up meeting in February that had about 40 leaders attend. So we find people in the public health sector, as you know, mental health's been in a fair bit of crisis, so that's been difficult, and it's been a little bit easier to engage with the NGO level of leadership as well. So that, of course, engaging right across is really important, and we're still actually doing that. One of the things we've developed is a consensus statement, and we want people to buy into that process. Right.
Okay. So you're gathering them along with you.
Yeah, that's a short answer.
Yeah. It's a short answer to a massive problem. We've been running training sessions, and quite a few staff from mental health, and one of their biggest issues is what they're asking for is a paradigm shift in, you know, the philosophical underpinnings of services, and that's not to be sneezed at when you're changing from a model of expert patient care to one of, you know, biopsychosocial co-design kind of processes. That's not an easy ask.
No, and I think, you know, under resourcing, I think we have to be realistic.
Right. Okay.
And using resources, in innovative ways that encourage community responses, I think, rather than just always rely on putting pressure on the specialist systems.
Yes. Yeah. Great. Now, Marion, I had a question for you. If I can come back to you, get you to come off mute.
Yeah.
With the predictive modelling, can you give us a little bit of a snapshot about how other people are using that? Are other people using that, or is this really innovative?
Yeah, so we're pretty excited because nobody in Australia is doing this work that we're looking at. So what's unique to what we're wanting to do is use the analytics and combine it with the actual rosters. So some people are doing predictive risk modelling around, you know, surgical interventions and adverse events, for example, orthopaedic adverse events, but nobody's looking at the whole picture and what actually affects that around the staffing. So we're pretty excited that we're looking at doing this in South Australia and you know, working with some really good people to pursue it. So yeah, it's good, it's unique.
Great. Okay, well look, you are my two favourite people because you are on time and right on the money and on the ball. So thank you very much. I'm sure that our participants will join us in a virtual clap for you. So thank you. And we look forward to the talks for next week. So thanks very much.